I was asked to speak about diabetes and medications, which really today we're going to focus on type 2 diabetes. So I'm not talking about type 1 and I'm not talking about gestational diabetes and in particular medications, and I've cut that back even further to not speak about insulin, but I'm happy to because I think that's a topic in itself. I'm happy to answer any questions on that, however, because I think there's been a lot of movement in the diabetes medication space and we need to perhaps go through them in a little more detail. Before I start, perhaps just have a little think with your table or amongst yourselves about, I haven't put any case studies in my presentation, mainly because I don't know whether my case studies are what you want to know or whether there are other questions and things like that. So I want you to, in the first few slides, maybe have a think about the last few people you've seen with type 2 diabetes, what kind of questions came up in your mind that you maybe didn't have time to look up or really would love to ask in this situation. So these are my disclosures. My children did help me with my slides, and so I apologise for any bad cartoons. Diabetes, I don't need to tell you, is very, very common. You guys deal with majority of it. I see the complicated end of it. One person diagnosed every 5 minutes is a lot of patients. We have a lot of patients affected, but a lot of carers affected too, and a lot of leave that's taken for this condition, and it's a costly condition as well. So I thought I'd bring up a diabetes map of Geelong, and in this case we have areas with lower incidences of diabetes. The red is the higher incidences, and then blue is lower. But essentially, we are living in an area that has a lot of diabetes. And some of the diabetes is not captured by this because these are people registered with NDSS. So some people have never been registered, don't want to be, or don't know how to be. So this is when life was easy. We had... Oops, oh, that hasn't come up. Anyway, looks like we have nothing on here. So we had metformin to start with, or lifestyle really, and then we waited for that to fail, and then we had metformin, that's the second box you can't see. Then we had sulfonylurea that we added in after that, and then we had insulin. And that was pretty simple because we had this really stepwise thing. We only had about 4 things, and I hope that the next slide's got some names on it, because otherwise I'm going to have to remember the order. Now what we've got as second line therapies, which is, love having a run through here, is that in the top box, you're just going to have to remember this now, is lifestyle and metformin. So we start metformin even in pre-diabetes. You know, we know that it prevents type 2 diabetes. We know that it has some very good vascular benefits and progression of diabetes benefits. So we start it early. And I've been asked about this quite a few times, and I'm happy to answer questions on that, but I'll push on and talk about these other blank boxes. Over here is your sulfonylurea. You can still start that second line. The next one, I believe, was the SGLT2 inhibitors that I'm going to go through in detail. Our other oral therapy, which was DPP4 inhibitors. Acarbose, very old-fashioned, I'm not going to talk about it today, but I'm happy to take questions on it. Basically, we'll come to why I don't talk about it. GLP-1 agonists, so subcutaneous injectable agents that can be used second line, and again, I'll show you some evidence on those. Hopefully it's not all blank. And then we've got the thiazolidine, so rosiglitazone, pioglitazone, again, unlikely to use them second line at the moment, but they were very popular about sort of 10, 15 years ago, and insulin at the end there. Oh, yay. I think I remembered them in order. Okay, so now third line, it becomes really confusing because we've got both not only what goes with what, but also what does the PBS allow, and then what about the drug-drug interactions, and well, what's combined with what? So on your tables, I've actually taken this from the Barwon Health document, and it's basically got a list of all the possible combinations and permutations, and then also the drug names, because I wasn't allowed to put drug names here. So things like, well, what do you call a DPP4 plus a metformin, and what those names are. So hopefully that's a list on your table. And really, what I wanted to illustrate here is that it really is an individualised choice for type 2 diabetes in second and third line management. Again, I'll mention why I don't choose these as second line. They are still very much on the market, and perhaps for some patients really should be on the market, because we know that some patients benefit, for instance, from sulfonylureas who have MODY, maturity onset diabetes in young, and there are some people who need just a really sniff of these things and get really good results from them. So they have their place, but I think as a second line therapy for your very much your patient with type 2 diabetes, you're really looking at some of these newer options now. The reason for the sulfonylurea kind of losing out a little bit is because the tendency for hypoglycemia and weight gain. The weight gain's not massive, although 1 or 2 kilos is still more than what we'd like. The lowered blood glucose is less so with the long-acting agents, such as what we use often here, which is glucoside MR, so that's to be kept in mind. Acarbose doesn't work very well, gives you flatulence. The glitazones, really their side effect profile has been their downfall, increased weight, increased fracture risk, and for rosiglitazone it's really off the market now because of the CV effects. So I'm going to talk about the other agents on the market aside from insulin, but also steer you in the direction of some of these resources. Obviously, health pathways, which is hard to keep up to date, especially with PBS criteria. So I'll direct you to that website as well. The RACGP guidelines are actually quite good, and some of the tables in here I've taken from there. The PBS website I'm constantly on. If you don't have your software dinging up and telling you about these sorts of things, it's often a nice reference source to look on. And then, pick up the phone, give us a call, check with the person next door if you're unsure, and those sorts of things. So just don't be afraid to reach out. Okay, and when choosing any medication, we then take into account all these things that we already take into account with any medication choice. Age, obviously the older the patient, the more comorbidities. We don't actually need a glycemic target down to 6.5 that I would target for, say, a young patient who has type 2 diabetes diagnosed in their 30s without complications. A patient in their 80s who has multiple risk factors for falls. The main thing is no hypoglycemia, and let's try and keep their A1C below 8. So there's individualising management that's going on with our patients all the time, and particularly if their health changes. The hypoglycemic tendency, so can the patient pick it up? Can they recognise it? Do they live alone? Do they have any other barriers to recognising it? And then the medication profiles, which I'll go through. Tolerability, we'll talk about side effects, we'll talk about contraindications and how to adhere to these medications. That's the other reason that I left that list on there, because some of these combination therapies have meant that for patients who are on, say, healthcare cards and things, 1 tablet once a day is going to be much easier than a twice daily regime, and much less expensive usually, and ease of use. So they're all the indications. These are how our glucose therapies work, these older fashioned ones, and we know that diabetes is affecting lots of different systems. Basically, the sulfonylureas target namely the beta cell and just push out insulin when you give them. The metformin, TZDs and insulin work at the level of the liver, the level of the muscle, and with TZDs also the level of fat. So we're targeting a few places there, but what I'm going to talk to you about next is some of these new agents that target, say, kidney reabsorption, that talk about neurotransmitter dysfunction and appetite, and also the islet cell, the alpha cell in the pancreas, which we didn't think did that much, but now we know it does. So, SGLT2 inhibitors. Everyone prescribes them. Hands up if you've prescribed one of these in the last 6 months. Yeah, they are very, very popular, and I'll show you why. This is how they work. This is the renal glomerulus, and what we have is glucose coming in the proximal tubule. Most of that glucose, 90% of it's actually resorbed back into the bloodstream. So there's very little in the natural state that is excreted in urine, unless you have this massive glucose load, blood glucose of 20, and you see glucose on your dipstick. And what an SGLT2 inhibitor does is it targets that receptor there. And you can see this in the blue. It has attached itself to the receptor such that the glucose is now no longer able to be reabsorbed. It is then continuing down the rest of the tubules until the collecting duct, and it is excreted in the urine. So patients are removing about 70 grams of glucose a day. They lose calorie that way, they lose weight, but they also get a slight diuresis and they get an increased risk of urinary tract infections and thrush, which I'm sure we've all dealt with in our patients. So these are the agents available in Australia at the moment: dapagliflozin 10, so Forxiga and Jardiance and Steglatro. So these three agents. We did have canagliflozin, which is now off the market. The effectiveness really depends on how they start. So if they start with a really high glucose level, I've seen HbA1c reductions much better than this. You can get almost up to a 2% reduction, how much weight gain they're getting and diuresis. But on average in the studies, it's 0.8 to 1%. The threshold for effect, so you'll notice in the PIs that the EGFR cutoffs are like this. So they want a greater than 60 for DAPA and a greater than 45 for EMPA and ertugliflozin. And the reason for this is not because that they're toxic above that with renal function below that, but just that they're not as efficacious for glucose lowering. And I can talk about that a bit more. I'm going to go through very quickly CV and renal data and the other benefits I've talked about with weight loss, again in the studies 1 to 2 kilos. Blood pressure reductions aren't trivial really, they're 5 millimetres of mercury systolic over about 3, that you're getting a reduction in blood pressure. The side effect profile, generally urinary tract infections worse in women than men and thrush, so about 4% of women, 1% of men. I warn all my patients about these. If they get treated, it is you can cure those things. Some people, unfortunately, and I'm sure we've had them all, have ongoing infections and we can't continue the agent, or they choose not to. There have been some recent case reports of very severe infections such as Fournier's gangrene and these sorts of things, which you can understand the mechanism behind, but again, that would lead me to cease this type of agent. There's also been case reports and now warnings on euglycemic DKA, and I thought I'd take it about 1 minute to talk about what that means. It means that the glucose level is normal, but patients have ketones and they can get acidotic. And the patients that develop this are usually either on a low carbohydrate diet, a ketogenic diet, or they are fasted for surgery, or they've got some other intercurrent illness such as a gastro or a viral, chest infection and those sorts of things, such that they're dehydrating. So we have had hospitalisations, we have had ICU presentations with this. Our recommendations are that patients stop these agents when they're unwell and that they stop them 3 days before any elective surgery. This is quite important for bowel prep. I've seen 3 people in the last week who just happened to see me around the timing of their colonoscopy, and I said, well, you're going to stop your empagliflozin, and they said, oh no, I wasn't told that. And so it's really important if you do see them in that instance, or even for other reasons, that you say, look, that needs to be stopped 3 days before you can resume it once you're eating and drinking normally. We've had procedures cancelled because of this issue. It's not overly common, but it is a bit of a complicating factor when you're prescribing them. Okay, so the cardiovascular data is impressive, and I could go on for an hour about this, but essentially a very high-risk population was studied in the EMPA-REG study, which was published now a couple of years ago. They were monitored. These patients had all had an event. They were all on everything we can throw at them, statins and ACE inhibitors and aspirin and etc. And they still had cardiovascular benefit with empagliflozin versus placebo. The dapagliflozin study was slightly different in that it was more a primary prevention study. They took in much bigger numbers and they did see a significant improvement in hospitalisation for heart failure. However, their population, being a lower risk population, didn't see the cardiovascular death outcome be significant. So I'll just show you what those graphs looked like very briefly. This is patients who had an event who were on empagliflozin versus placebo. You can see the curves separating there very nicely at 6 months. And then cardiovascular death, so a 38% relative risk reduction for cardiovascular death. So these agents, we love them. There are a couple of things that you have to watch for. And the renal outcomes are equally impressive. So the time to worsening nephropathy or doubling of creatinine or time to renal replacement therapy are significantly improved on these agents. So the renal physicians want in, the cardiologists want in. There are now studies ongoing for patients who don't have diabetes for these agents because of these data. So again, this is the incident or worsening nephropathy, and you can see that these patients had a much better outcome. Okay, so any questions on SGLT2 inhibitors or how they work, or... Oh, sorry, now I've thrown things out because the microphone's... So that question was about ACE inhibitors and angiotensin II receptor antagonists when you're using these agents. I would still use them together. I wouldn't stop them. The agents that you could consider stopping are the thiazide diuretics, so particularly because when you start something like these, you can see a drop in EGFR initially, and I didn't put that graph in. They drop their EGFR and then pick it up and actually are better than their placebo other patients. So thiazide diuretics or even loop diuretics I'd consider, especially if their blood pressure's really well controlled. You don't want it to drop further. There was Cameron.
So apart from the better diabetes control, are there known mechanisms why they might improve cardiovascular or renal?
Yep. Yeah, there are, and again, I didn't put up the information there in the interest of time, but essentially, if you're dragging glucose through a cell and then back through it again, you're basically giving it two toxic insults, and so the nephrologist, that's a very basic nephrology answer, but the nephrologists think that ability to kind of be toxic to your nephron cells is one mechanism for the renal benefits. It's not all explained by blood pressure, even though they lower blood pressure. It's not all explained by that. In fact, these were a bit more impressive than even the ACE inhibitor when we took that on board for their nephropathy. So we think it's probably cellular damage there. The cardiologists have come up with some very interesting theories on the fact that perhaps you are a little bit ketogenic, particularly when you're fasted overnight and the ketones are preferentially taken up by the myocardium and the myocardium functions better. I don't know whether that's the answer, but there are so many, and also the fact that the hospitalisation for heart failure is not all just because they're diuresing out. There's something to do with heart function. That's a plausible explanation, but I think we have a long way to know exactly why. It's not all diabetes control. In fact, it's probably not diabetes control, which, yeah, I'm happy to admit. Any other questions on SGLT2 inhibitors before I move on to this lovely group? Good. Okay, so incretins. These are, again, a love child of mine. I like these agents. These are very clever and I think have changed diabetes as well in the last little bit. This is what I mean by incretins. What they mean is that in our stomachs, when we ingest food, we have hormones released by the cells in the small intestine, and those hormones are called GLP-1 and GIP, and they work at the level of the pancreas to improve insulin secretion in conjunction with ingestion of food, and reduce glucagon. I talked about the alpha cell earlier, so that you end up getting a lower blood glucose in both fasting and postprandial states. And this occurs in normal health, but we know that patients with type 2 diabetes have impaired GLP-1 secretion. These hormones are inactivated by an enzyme called DPP-4, and so there are two ways to target this pathway. The first is if we increase GLP-1, so these are our injectable agents that I'll go through, Byetta, liraglutide, Saxenda, Victoza, Trulicity, Bydureon. So they're our injectable agents either once a day, twice a day, once a week. Or you can inhibit DPP-4, so you can end up with your own native GLP-1 circulating a little bit longer. They're oral agents, and they're very well tolerated, that I'll go through. Now, we don't use these two classes together, mainly same reason really that we don't use ACE inhibitors and ARBs together at the moment. They work on the same pathway. There's no known damage using them together, but we don't. So if you're going to start one, don't start the other. There are 5 agents available. I'll go through them. Again, 0.8 to 1%. The cardiovascular data is neutral for all of the studies. Saxagliptin did have a tendency to heart failure, but that was kind of very minor, and I guess not completely understood why that 1 out of the 5 had that slight change. You need to reduce the dose in 4 out of the 5 for renal impairment. So apart from linagliptin, the others need reducing. The side effect profile, they are very well tolerated. Recently there's been a bit of evidence about joint pain increasing, and I've had a couple of patients come off for that reason, and nasopharyngitis. But they're a great agent when you have an EGFR less than 30 and you're not sure what else you can use apart from insulin. And so these agents, and I'll come to which ones are on the market with insulin. So I thought this might help. We've got our 5 agents. We've got some that are combined with metformin, which is immediate release, and some that are combined with metformin extended release. There are now some that are combined with our SGLT2 inhibitors. So you can kind of hope to choose maybe whichever combination and permutation that you like. There's some listed for triple oral therapy on PBS. So if you want metformin, DPP-4 and SGLT2, you've got 3 options there that are combined. Some are PBS listed with insulin, so we make use of those. And then the ones that need reducing for renal impairment are all but linagliptin, which is Tradjenta. This is where they work. So GLP-1, I talked about the gut effects. They actually slow down gut absorption, so some people get GI side effects, which is the major issue. They also reduce appetite. And these are our GLP-1s. So this is the injectables. So we've got Byetta, that's been around for a while. It's the only GLP-1 PBS reimbursed with insulin at the moment. So it's twice daily, injected before the meal, 30 to 60 minutes. It's a bit of a pain for some patients to wait that long to eat. You start 5 mics twice a day, up to 10 mics twice a day as required. Lixisenatide, I must say I haven't used, it's not PBS reimbursed, it's a short-acting GLP-1, and so it's only private script. And exenatide extended release, Bydureon this is. The pen's getting better, I'm being told. Otherwise there is a few little tricks with the pen of how to use it. It's PBS reimbursed, but only with metformin or sulfonylurea or met and sulf. So you'll see sometimes patients come on a sulfonylurea for that reason. Once weekly, doesn't need to be with the meal, and leaves a little bump under the skin, that one. Liraglutide, again, not PBS reimbursed. This is Victoza or Saxenda. The Victoza is up to 1.8 milligrams, and we titrate it usually weekly as tolerated. Saxenda's on the market not for diabetes but for weight loss, and you can go up to 3 milligrams. Gelaglutide is the newest one, whose PBS reimbursed much the same as Bydureon. It's called Trulicity. It's once a week, and there's one dose, and the pen's pretty easy to use. So how do we choose between these agents? There's short-acting, really PBS reimbursed is Byetta, and there's long-acting, we've got those three agents. And we think that there is a difference between the short and long-acting. The short ones tend to cause more GI side effects, so if someone's having trouble with that, then they certainly should be transitioned onto a more long-acting agent, a weekly agent. The effectiveness is significant, so these agents should be used when you're thinking about starting an injectable. That's fairly new. We used to say, well, insulin first, or just if someone's symptomatic with hyperglycemia, insulin's still a great option. But if they've got an A1C that is quite elevated, 9-10%, but they're not symptomatic with their hyperglycemia, you really should give these guys a go as your first injectable. And there's a few reasons for that. Mainly because of the lack of weight gain, or actually weight loss, and also some of the cardiovascular benefits that we've seen for some of the agents. So which ones have benefit? Well, liraglutide, so this is the unfortunately non-PBS reimbursed one, has shown a cardiovascular benefit. Lixisenatide and exenatide have had a neutral effect, and this hopefully will come, semaglutide, because that's looking very promising, and hopefully we'll get PBS reimbursement. EGFR above 30, nausea gets better with time or with the long-acting. I'm going to end in 2 slides and ask for questions, but this is, I know not Australian, but a very nice paper that lists a great flow diagram, I think. I know this is busy, but bear with me. First line's metformin, it says, and lifestyle. We're about to talk about exercise, which I'm looking forward to. If they've got established cardiovascular disease or chronic kidney disease, and the cardiovascular disease, so they've had a heart attack or got a stent, if that predominates, then either use a GLP-1 that's got cardiovascular protection, and in this country, liraglutide is non-PBS, but if they'd like to use that, or use an SGLT2 inhibitor that's got cardiovascular benefit. So in this country, that's empagliflozin. So then if you're above target, you can consider adding on therapies. So I think this gives us a bit more guidance with second line. If heart failure or chronic kidney disease predominates, then you use your SGLT2 inhibitor that has got evidence. So we've now got evidence in all three of our agents. And then if you're above target, you can work out what you want to do next. If there's a compelling need to minimise hypoglycemia, you can see that there's quite a few options there. If there's a compelling need to minimise weight, they're talking about, again, GLP-1 or SGLT2, or if cost is a major issue. This is for countries where they don't have a similar system to us with PBS. And I just thought I'd highlight that change, and hopefully I think this is likely to come into the Australian guidelines and make it just a little bit easier for you to choose that best second-line agent for the patient in front of you, knowing really their cardiovascular and their chronic kidney disease risk or risk factors. Are there any questions there on anything? I can. That one? Yep. I'd be happy for them to, or at least the reference to click on to, because it's freely downloadable. So I'd be happy for that to happen. They're just not Australian, is the only. I don't know whether they've got to be Australian.
So do you think the PBS guidelines are supposed to go right?
Look, they have improved considerably, I think, is what the PBS guidelines have done. I'm waiting with bated breath for them to combine the SGLT2 and the GLP-1, because we've got data in that sphere. I often do it, but something's got to go on private script, and so it's really for a lot of people unaffordable. But when you look at the data of both agents and what they can do, and then there's small studies combining them, like duration 8 and those sorts of things with Trulicity and SGLT2. The data's fantastic. You know, you've got two agents that don't cause hypoglycemia. They both cause weight loss. They both, they improve blood pressure, improve kidney function and cardiovascular death. I think, we're sort of waiting with bated breath until that point. The other combination I'd like to see is a long-acting GLP-1 with insulin. So that it's not just a choice of, you inject twice a day Byetta and then you've got to add insulin. And I've had some people come and see me, they're on 6 injections, I'm sure you all have, 6 injections a day. The injection burden is considerable, and if they could move that to a weekly and then plus insulin, that would be lovely as well. So if I had my wish list, it would be those two things. Yes?
Not exactly related to this, but I was just wondering, young girls with PCOS, should you measure fasting insulin and should you think about metformin?
That's a good question. So patients with PCOS and metformin. So we know that they probably don't all need to go on, and at this stage we don't have a great insulin assay. So I'd say for the majority of the time, and also insulin depends on whether they've eaten or they haven't. So a fasting insulin level, it can tell you a little bit, but the variability at the lab is so wide at the moment that I wouldn't use it as a routine. What I would do with all my PCOS women, if I was considering it, is, look for the signs of insulin resistance. You might see that they've got acanthosis and all the rest of things. Or do an oral glucose tolerance test and see whether they've got impaired glucose tolerance, because some of these girls really do. And then, those patients are then put on metformin. The other place metformin has a role in PCOS is fertility planning. So we know with ovulation induction, metformin added to either on its own or added to some of these agents helps with achievement of pregnancy. So I'd avoid the fasting insulin until we know a bit more. And that's from the PCOS guidelines from Helena Teed in Melbourne, till she tells us that the assay's got a bit better. This side. Oh, someone's getting their steps up by doing this.
I am.
It's very good.
Thank you. Back to the beginning when you talked about pre-diabetes and metformin. So some labs, like clinical labs, use 5.4 as their cutoff, like the WHO, and some labs like Dorevitch use 6.0. So what level of pre-diabetes do you call pre-diabetes, and what level of pre-diabetes HbA1c, like fasting sugar of 5.8, HbA1c of 5.8%, what level of pre-diabetes do you start talking metformin?
Yeah, Again, the lab issue is a big one, and we had that with gestational diabetes for quite some time, where they're all reporting different things, and you could be in a different state and have gestational diabetes and come to a different state and you didn't have it, and it was it's a nightmare actually. So I'd consider above 5.5, it's a warning, and if you're above that, I think your best next test. I know HbA1c is easy and above 6.5 for your HbA1c, yes, that's where we'd start looking at diabetes diagnosis and things. So I'd do an oral glucose tolerance test and repeat it, because the more measurements you've got, the better. But above 5.5, I think you've got to start thinking about, the risk in that particular patient. Do they have a family history? Are they overweight? Have they, what is their risk of having type 2 diabetes down the track? But I would do an oral glucose tolerance test. I know the patients hate them, but it gives you so much more information, because the postprandial tends to go up first before the fasting too. So if you're a bit borderline on your fasting, you might come back and see that they're 8.5 at 2 hours, and then you've got your answer. You go, right, okay, you really are heading down that path. And you can then talk about, lifestyle, definitely. That has not taken a back seat. Kathy's going to talk about that. And then metformin as well.
So you're saying if they're pre-diabetic and they look and feel pre-diabetic,
that's right.
That's when you're talking metformin.
Yep.
If they're pre-diabetic but they don't look and feel pre-diabetic, they're lean, skinny and everything else is all right, those ones you might not talk
I'd,
metformin.
I'd still do an oral glucose tolerance test and then and talk about, because some of these lean skinny people actually, you know, you take a dietary history and it's really not that great either. So, you know, still talk about these sorts of things, but I tend to watch over time. You know, you can always repeat, just flag them. Okay, sorry, I know I've gone over time now.
Thanks, Kimberly.